Thanks, Leslie. Appreciate it. Hi, good morning, everybody. How are you today? My name is Jonathan Jenkins. I wear a couple different hats actually. So I am a paramedic, primarily. That is my life, right? I'm a paramedic. I do critical care transport, just like you guys. But also on the side, dabble into some research. And with that research, I'm affiliated with the Lights Network, which is the pre-hospital research arm of the University of Pittsburgh. And with that said, what we're going to talk about today is this thing called the pre-hospital analgesia and intervention trial, or what we affectionately call as the pain trial, that you guys in Vermont are going to be participating in. And a couple weeks ago, 3 weeks ago ish, our team was up in Vermont, and we did a lot of education with some of the ground EMS services, and now we wanted to double back and touch base with you guys as the air transport provider, as you may see this out in the world and are going to be carrying it on your aircraft. So first and foremost, what is the Lights Network, right? So this is something that most people have probably not heard of. And this is essentially a network of pre-hospital research. So what happened was about 10 years ago, some folks in the emergency medicine and trauma departments at the University of Pittsburgh got together and they sort of had this vision that, like pre-hospital research is really hard. And if we can net together several EMS agencies and multiple hospital systems from around the country, we could probably get some pretty high quality work done. So that's what they did, and they started to build this thing. And LIGHTS stands for Linking Investigators in Trauma and Emergency Services. And over about the last 10 years, they have implemented and either completed or are working to complete several different trials. So they've looked at things like cold stored platelets in TBI and in shock. They've looked at things like pre-hospital whole blood, pre-hospital airway care. We're currently the airway study is almost done. The Tower study, which is the whole blood study, is almost done. The Cavalier study, which is vasopressin and calcium gluconate hemorrhagic shock, that is just starting up. It's kind of like in the same phase as pain is. And they've done this, and this has now become a system of about 50 hospitals, probably 2 times that amount of EMS services. It's about 4,000 paramedics that participate across the country. And they've done some really good work. And the work that you guys are going to be working on with us in Vermont is pain. So again, that's the pre-hospital analgesia and intervention trial. And really what this trial, starting with the end in mind, seeks to discover is what is the best way to manage pain in pre-hospital trauma patients. And what we know is that if we have patients in shock, right, they're in significant shock, and we manage their pain, they do better, right? And that's great. But anytime we introduce medicine into their body, there's always a risk. And we also know that if we don't do anything for them, then they're at significant risk of all of those H-bomb type things, right, that we learn about, right? The hypotension, the hypoxia, so on and so forth. So the goal is to try to figure out, does pain management reduce mortality? And if it does, what kind of pain management is the best kind of pain management? And most commonly, when we think about pain management in EMS, it is fentanyl versus ketamine, and that is exactly what we're going to look at here in this trial. So, does fentanyl or ketamine help manage pain more effectively? Does one manage pain more effectively than the other? And does one reduce the mortality? And from a pharmacokinetics and dynamics perspective, while these drugs have similar properties to some respect, they're really largely different, right? From a ketamine versus fentanyl perspective, they have relatively both have relatively fast onset times, but their durations vary significantly, and where they work on the cells and in the receptors in the body is really a lot different. From a ketamine being an NMDA agonist versus an opioid receptor agonist in fentanyl. So they really target different areas, and they're both really effective, right? Like we can all agree that we have given patients one or the other and had really good results with both, right? Like they do really good things, but they're just not created equal. And with that said, we have to try to figure out in trauma, does one make a more profound difference than the other when we're taking care of these patients that have really delicate physiology? And we also know that they both have significant side effects, right? Like when we give a patient ketamine, it's not super uncommon for that patient to maybe have some respiratory pattern changes, right? Or to get that really sort of that emergence reaction feeling where maybe they're a little bit partially dissociated, which is not good, versus fentanyl, where we can have these patients potentially become hypodynamic, so they're hypotensive, their heart rate might be a little bit tachycardic, they get this nausea, this vomiting, they get this real jittery feeling. So certainly there are side effects, and we're always able to help people through these side effects. But obviously, the side effects are not something that we love, and we have to be aware of that. And we're going to talk more about those as we work through this. But it's important to sort of start with these things in mind because, as you all know, everything that we do in pre-hospital medicine is a little bit of a give and take, right? If I give this patient fentanyl to accomplish A, B, and C, sometimes we do that with the risk of D, E, and F, right? And we have to always weigh that out. And that's part of what this study is. And that's what we're going to talk about here. So how did we get here? So, like I mentioned, pain management is associated, or lack of pain management rather, is associated with higher risk of mortality. That makes sense. And this thought that the current options that we have, while we know that they do work, are relatively unsatisfactory as it relates to, yes, they manage pain, but are they really decreasing mortality? Are they really promoting better outcomes? And pain management is an essential thing. I can't speak for your helicopter program, but the ones that I interact with on a regular basis from a clinical perspective, we give fentanyl to people like like constantly. We give fentanyl. Somebody asked me one time, like, how much fentanyl do you think that you give a year? Like gallons is probably the answer. Like I don't know, but like it's a lot, right? And we do it because we give little bumps, 50 mic bumps of fentanyls for pain management, or we give it for airway care, or we give it for whatever, and we give it all the time. But we know that while it is essential, it is really inconsistent. Like think about the way that you manage pain versus the way that another program manages pain, or just the way that your pain management methodologies vary just within your own system based on clinician, right? Everybody's approach is different, and this is a feared thing in the EMS community, for any number of reasons, but not the least of which is that there are side effects. And now, especially more than ever, in the popular culture world, um, that pain management has become this really hot topic of, it's possible to get addicted and so on and so forth. And while that's all true, from a healthcare perspective, we understand that it is actually relatively safe so long as that it is done correctly. So this really comes from the question of how do we do it effectively, and how do we do it in a way that is consistent and essential and safe. And this question actually is posed to us from the Department of Defense, because the military encounters these patients often, and they are trying to always figure out which the best way to manage these patients are. That's really where the question comes from. And we know that there's several different ways to do it as it relates to what the current standards are, right? Most of us use that numeric rating score, from 0 to 10. Tell me how bad your pain is. Most of us are using opiates, fentanyl or morphine, and And we're really good about not managing these patients with an abundance of pain medication when they have really delicate physiology. But we also know that even in the patients that have pretty solid physiology, as we introduce these chemical substances into their body, there are risks of being able to become hypotensive or hypoxic and so on and so forth. And it's this delicate balance of trying to pick the right medication for the right person. And I know that that sounds really redundant, but I can't emphasize it enough that what we do currently is working, but we're trying to figure out what the best one is. And this is really important to the DoD because from a military perspective, these patients have often long field times with limited resources. And because of that, they're not always able to move a patient from point of injury to tertiary care in a really fast, efficient manner. No fault of their own. It's just how it shakes out. So they always want to try to um, manage these patients most effectively with the tools they have, with the best possible tool for the best outcome, given the fact that their time to tertiary care might be significantly longer than that in the civilian environment. And then what we also know from war times, unfortunately, is that much of the resuscitation tactics that they have carry over into the civilian environment as it relates to what works and what doesn't. So this is really why the military environment in DoD questioning and DoD EMS research funding is applicable to civilian EMS. So so that's sort of how we got here. And I think it's important that we understand what we're looking to figure out. So first and foremost, who else is playing in the sandbox, if you will? Um, so so there are EMS agencies across the country that are assisting. So in research, a site is a hospital, right? Is a hospital is an academic place, maybe a university that is essentially sponsoring the research study. So in your case, that would be the University of Utah. Or oh my gosh, I'm looking at Utah, at the University of Vermont, not Utah, wrong side of the country. University of Vermont. It's cold there too in the winter, but not the same thing. So University of Vermont, and then inside the University of Vermont's umbrella, there are several different EMS services that are participating, and that is true around the country, right? So, and there are some big EMS services that are participating. For example, last week we were doing some education with San Diego Fire Department, who runs their EMS. They were telling me they have 650 paramedics in their system. Like that is a huge EMS system. I couldn't even fathom that. So there are a lot of paramedics, 4,000 to be most specific, around the country that are participating in this. So it is a cool thing to be involved in what is essentially a clinical trial that will have reach across the country. And what the pain study is, getting into sort of the nitty gritty here, it is a randomized, double-blinded, EFIC, so exception from informed consent, and we will talk about that here in a moment, clinical trial that is comparing fentanyl for ketamine. We are expecting that it will take about 3 years to enroll the 994 patients. Now, that 3 year clock started last year. So we're thinking probably 2 years at this point. Vermont you guys are the last like really large EMS system to come on. We have some smaller ones that are participating, but as I know, and I could totally be wrong, but as I know, you guys are going to be the last sort of small or last large EMS system to come on, which is going to be really great because that will help significantly. And we got to enroll 994 patients. And remember that that's not 994 patients in Vermont. That's 994 patients total across the country. So, randomized, double-blinded EFIC trial that is comparing fentanyl for ketamine. And the primary outcome of this study is does one versus the other, so IV ketamine in a subdissociative state versus IV fentanyl, reduce 24-hour mortality. in these patients. So that's where we're at. Does one reduced 24-hour mortality better than the others? But as you might imagine, with all of the data that gets collected, in a medical record, there are some other things that we could probably try to figure out as well. So while the primary goal is 24-hour mortality, we're also going to look at frequency of hemodynamic collapse, for lack of a better word, right? So, do these patients have do patients that have one or the other have higher instances of hypotension and hypoxia and hypocarbia and so on and so forth? And is there a is there a patient that does better with one versus the other as it relates to PTSD and anxiety? So we will continue to follow up with these patients for a longer period of time. Excuse me, 6 months, I believe, um, after their administration, to talk to them about sort of their recovery process and to collect some data that way. And then, is there a reduction in complexities that occur as it relates to things, not only like the anxiety and the PTSD, but do they now have a long-term use, for one reason or another, of opioids or otherwise, and is one better than the other at reducing pain, right? So there's a lot of different secondary outcomes that can come to play, but really the big question is 24-hour mortality. And this is going to be, I think, really interesting, because where we focus our efforts is really focused on what we know. And that, what I mean by that is in the pre-hospital environment, we are really interested in, does one reduce pain better than the other in a safer manner, right? Like, that is really the bottom line question. Can I give a patient X versus Y and have one be better than the other and them be safer hemodynamically? In the hospital, they're interested in, does the patient have reduced pain and a better hospital course? So do they have less pain when they show up, and do they potentially need less resources or different resources? And then from a follow-up outpatient perspective, how well do they recover, right? So this study will allow us to look at this from a couple different angles that will allow a couple different stakeholders, pre-hospital, in-hospital, and then post-hospital, to be interested in their outcomes. And this isn't necessarily as important to any of us, but to the research community. They will also look at some sub-analyses here. They're called secondary analyses, which will take a look at various different things that could come to be. So the way the Lights Network works is, when the study is over, all of the data that is collected is disseminated to all of the places that participated. So, for example, we'll pick on Dr. Wolfson. If Dr. Wolfson is one of the physicians that helped facilitate the study through the University of Vermont and his EMS agencies, post study, he will have access to all the data, and then is able to take folks from his EMS systems, from his hospital system, whatever, and say, looking at this data, a question that I think is really interesting is, is fentanyl or ketamine better in, let's just pick, like, male versus female, right? He'll be able to take that data and then look at that and create his own secondary analysis of the data that is then able to be published, and so on and so forth. So it opens up the door to have a really strong data set to answer some other hard questions that come to be. So that's what it is and how we got here. And let's talk about the criteria. And this is going to sound like my sort of fifth grade teacher plug, but if you listen to nothing else that I talk about this morning, please listen to this part, because this is the really, really important meat and potatoes of this. So here's how this will work. And I will show you some pictures as well, but here's how this will work. In your helicopter or in the ambulances, you are going to have what looks like a brown colored Ziploc bag. And in that brown colored Ziploc bag, you will have two syringes. Both syringes will either be fentanyl or ketamine, and we'll show you some pictures of them in a minute. And in those syringes, there will be 10 mLs of volume, 10 mLs in each syringe. And that's the syringe that you will use to manage the patient's pain. So to manage the patient's pain, they have to meet certain criteria. You can't just pull this Ziploc bag out with our special syringes in it and give them to any patient that you take care of. It doesn't work that way. They can only be specific patients. So who can the patients be? First of all, it has to be a patient that has sustained a traumatic injury that is being transported to the University of Vermont. No other hospitals. Right? So it's got to be going to the University of Vermont. That's the first thing. So trauma patient going to the University of Vermont. They have to have a shock index greater than 0.9 or 0.9 or greater, right? So shock index, remember, that's heart rate divided by systolic blood pressure. And if that number is 0.9 or greater, they're good. And they also have to have a pain score of greater than or equal to 5 if you're using the numeric score, or a CPOT score of greater than or equal to 2 if this would be a patient that was maybe sedated or something like that. So if they do not meet those criteria, and it's not one or the other, it's in addition to. So trauma patient going to the University of Vermont with an elevated shock index of greater than or equal to 0.9 and a pain score of 5 or greater, or greater than or equal to 2 if you're using a CPOT. Have to meet those criteria. If they do not, they can't be enrolled. Yes, I saw a hand go up somewhere. Michelle, sorry, it popped onto
Yes,
my other
yes.
screen.
For the UVM part, since is it UVM and all of our like are under our umbrella, or just the building?
Just the medical center.
Okay, just checking. Thank you.
Yes, and I'm going to defer to Leslie for that one, but that's as I understand it as well. It would just be the trauma center that's at the medical center.
I saw Dr. Wolfson on, and that was my understanding. It was only patients coming to the medical center.
That's, yeah, they can be coming from anywhere, but if you're bringing them back to UVM, so if you're flying to Dartmouth, then you would not enroll them if you know that that's where you're going. But anybody coming to UVM can be enrolled, even if you're transferring them from another hospital or from the field.
I think sometimes we go to we take patients to Plattsburgh, Dan, not necessarily a trauma patient, but I think that's where Michelle was coming from.
Yeah, so if you're going to Plattsburgh, you would not enroll them.
Danielle?
Does it matter if they are IFT versus seen, and if they've had prior pain medication before this rating of 5?
Yeah, so great question. It does not matter if they're IFT versus seen. So you can anybody from a seen or from a referring facility can get managed. That is totally fine, no problem. And no, it does not necessarily matter if they have had pain management prior to your arrival. That is okay. But there is a caveat, and we're going to talk about it in the exclusion criteria, is if they've had their airway managed prior to your arrival via an advanced airway. So, if you get there and like the medics on the ground are bagging, that's fine. But if you get there and they're intubated or they have a supraglottic airway in, then they cannot be then they cannot be enrolled from that perspective. So no, it does not matter if it's IFT or seen, and no, it does not matter if they've had pain management prior to your arrival, and that will make more sense here in a second. So
thank you.
No problem. Great question. So again, inclusion criteria: going to UVM, to the trauma facility, to the medical center, as Leslie said, with a trauma patient. Shock index of 0.9 or greater, and an elevated pain score defined as 5 or greater or 2 or greater, depending upon the score, the scale you're using. If they meet those criteria, you are able to enroll the patient, as long as they do not meet any of the exclusion criteria, right? So they have to meet the inclusion and they can't meet the exclusion. Here's the deal. So from an exclusion perspective, first and foremost, they have to have IV access. We cannot give the study medication any other route via IV, including IO. And I know that that's a little bit goofy because I, like you, understand IOs, that anything we give IV, we can give IO for the most part. With the exception of this study, cannot give it IO or via any other route. Also, we cannot give this to any of the protected Ps, if you will, of research. So no pediatric patients defined as less than 18 years old, no prisoners of any kind. And when I think prisoner, I think of jail, right? And the reality is, a prisoner in the eyes of research is anybody that is detained by the police. Here's the way I explain it to people: if they're in handcuffs, don't enroll them. Just leave them go. And if you're really not sure and you're like, is this person a prisoner? Like, I don't really know. Err on the side of caution. Don't enroll them. So no pediatrics, no prisoners. And the other big one for this study is that we cannot enroll any females less than 50 years old. And the reason for that was because because of the risk of pregnancy, and that we fought that really hard with the FDA, and they would not budge on that. And from a EMS perspective, you guys will probably laugh about this a little bit. The FDA's give for that was, if we wanted to enroll females less than 50, you had to do a point of care urinalysis pregnancy test in your helicopter. And we said, that's okay, we'll pass. I can't speak for you. I don't much like people peeing in my helicopter on purpose. So if I can avoid it. So no females less than 50. If you have a female older than 50, certainly not a problem, but no females less than 50. And those are the big ones. In addition, just some housekeeping exclusion criteria, if you will. Cannot enroll anybody that is hypertensive, defined as a systolic pressure greater than 180, because there is a chance you're going to give them ketamine. Obviously, we wouldn't enroll anybody that has a known allergy to fentanyl or ketamine. And you can't enroll any patients that contradict your protocols. And what that means is, let's pretend that you have a protocol at your program that says we don't give pain management to patients that have a blood pressure less than 90, right? Let's just, for sake of the discussion. If that's the case and this patient has a blood pressure less than 90, you can't enroll them, right? Because giving them pain medicine would be a protocol deviation. So nothing that violates your local protocols. As we talked about with Danielle's question, nobody that has an advanced airway placed prior to your arrival on the scene. So whether that be on a scene or in a hospital, if they have an advanced airway, cannot enroll them. If you have to manage their airway after you give them the study drug, that's no big deal, but no advanced airway prior to study drug. And then finally, anybody that voices an objection. So anybody that says, hey, I don't want to be enrolled, or anybody that is wearing one of the no pain study bracelets, which I will show you a picture of here in a moment, that are enrolled. So as part of an EFIC trial, we have to do what's called community consultation. So we have to make the community in which you serve aware that this is happening, and then those folks have the ability to reach out to us and get an actual bracelet. They look like those yellow Live Strong bracelets that people used to have that say no pain study. So that's how the inclusion and exclusion criteria will work. So have to meet the inclusion, can't meet the exclusion. And somebody put a question in the chat. Danielle said, what about the dose? Could be outside the guideline, but I imagine you'll be telling us what's in the syringes. Yes, hold that thought. Stand by like 1 or 2 slides and we will talk about the dose. Can I change the slide?
Yep.
There we go. All right. So again, inclusion criteria, right? Trauma patient going to UVM. Trauma patient going to UVM. Shock index defined as heart rate divided by systolic blood pressure of greater than or equal to 0.9, and a pain score of 5 or greater or 2 or greater, depending upon the pain score that you're using. In your helicopters, in your bags, however it will be set up, we provided Alex Newman from University of Vermont to disseminate to you guys the reference cards. So there's like shock index charts and those sorts of things that will be supplemented material with the study medication kit, so you have those for reference. And there's a question in the chat. If you're supplementing their with blood impressors, with their blood pressure with blood impressors, can we still give it if the systolic blood pressure is greater than 90? Yeah, for sure. As long as your protocol allows that, that's fine. And Dr. Wolfson said yes. So no problem. Numerical rating score. I suspect that we probably don't have to spend a lot of time on this, right? 0 is no pain, 10 is the worst pain of your life. Tell me where you fall on the chart. That's a pretty self-explanatory one for most of us. So general numeric rating score or the CPOT score. And as a helicopter service, I would imagine CPOT is a pain score that you guys are relatively familiar with as you take care of much more nonverbal, chemically sedated, so on and so forth, patients than the average ground EMS system. And if that is the case, and you're taking care of one of those patients, certainly it's still important that we manage their pain. And in managing their pain, this is the CPOT score. There is a CPOT reference that is on the reference material as well that we sent to Alex Newman to disseminate to your program. So you will have that as well. Exclusion, and again, I don't want to sound redundant or beat a dead horse, but really important that we think about the inclusion and exclusion. And the way that I do it is when I'm taking care of a patient, I look at the inclusion and I say, does this patient meet the inclusion criteria? And if the answer is no, I don't ever have to think about the exclusion criteria, right? Because I can't enroll them anyway. So, but if the answer is yes, we have to make sure they meet the inclusion and then make sure they don't meet the exclusion. So again, just to reiterate, got to have IV access, right? So can't enroll patients that don't have IVs, nobody less than 18, no prisoners, no potentially pregnant females, so no female less than 50, nobody that is hypertensive with a systolic greater than 180, nobody with an allergy to known allergy to fentanyl or ketamine, nobody that would contraindicate your local protocols or guidelines, nobody that has an advanced airway, and then obviously nobody that objects or is wearing one of the bracelets. And this is what the bracelets look like. They're a blue colored like rubber bracelet that says no pain study on them. And if they have a no pain study bracelet, that is the same thing as saying I don't want to be enrolled. So that's what they look like. And I will tell you, people do request them. We have sent them out around the country. I would be pretty shocked if you see one of these out in the wild, not because we don't send them out, but just because there's very few people that really object to that kind of stuff, but they do exist. So do take a look at them or take a look for them. Be respectful of those sorts of things, but probably unlikely that you will encounter them. 0 bracelets that have been requested to date in Vermont. So, okay, if you see one, that'll be very cool. It'll be like a unicorn. Yes, Michelle, go ahead. Fire away.
When we're taking care of these patients, do we need to talk about it with them in the moment? Be like, I'm giving you some pain medicine and this is like, or do we just give them pain medicine?
If you can hold that thought for 5 minutes, I'm going to talk all about that. The short answer is no, but hang tight 1 second.
Okay.
So coming back to Danielle's question about what does the dose look like. So here's what the kits look like. There are these brown Ziploc bag looking kits. And it's probably hard to tell in the picture, but they're perforated down the middle. And in each kit, there are 2 syringes. There are 2 20 ml syringes, and each syringe has 10 mLs of volume. So my first question was like, why didn't we just use 10 ml syringes? Fun fact, the FDA doesn't allow 10 ml syringes. They have to be 20, even if they're only half full. Fun fact of the morning. So there are these brown colored Ziploc bags, and on the Ziploc bag, there is a label. And if you blew up the label, this is what it looks like on the screen. So there's a couple things on it that you should be aware of. It'll have a lot number and an expiration date, just like any other medicine that you would give. It has a QR code on it that you will have to scan following the administration. So when we'll talk more about that here in a minute. And then at the bottom, it has phone numbers for the primary investigators for the study at the University of Pittsburgh. So Dr. Jason Sperry and Dr. Frank Guyette. Jason is a trauma surgeon, and then Frank is a emergency physician. It has their phone numbers on it. So if the hospital were to really need to know what this patient got, they could call those numbers and get this medication unblinded if they needed to. And then at the top, it has the dosing information, which we will talk about here in a moment. So this is what they look like. So circling back to Danielle's question, what about dosing? This is the other really important part. So 2 syringes, 2 doses. Okay. So what happens is you can give the patient 1 dose of pain medicine, and then in 15 minutes, if they're still in pain, you can use the second syringe and give your second dose. So the syringes, somebody much smarter than me figured out how to make the quantity of medication equivalent. So in each syringe, there's 10 mLs of volume, and that 10 mLs of volume comes out to be 10 mics, 10 mics per ml of fentanyl, or it comes out to be 2.5 milligrams per ml, 2.5 milligrams per ml of ketamine. The dose for this patient, or for the dose of for the patients, is 1 ml per 10 kilos. Okay, so it's 1 ml per 10 kilos, which means you could give a max of 100 mics per dose or 25 milligrams of ketamine per dose. So, for example, if I had a 70 kilo patient, they would get 7 mLs of volume. And that 7 mLs of volume would either end up being that would either end up being 70 mics of fentanyl or 17.5 milligrams of ketamine. And you don't have to worry about necessarily, like, unless your program were to want you to do it and you would follow their guidelines. But like, you wouldn't have to chart necessarily how many mics or milligrams you gave, because you don't really know. You can just chart the volume. So was taking care of a 70 kilo patient, administered 7 mLs of pain study medication, right? And that comes out to be what that is. So the dose is 1 ml for every 10 kilos that they weigh. If they weigh more than 100 kilos, let's say, right? If a 100 kilo patient would get 10 mLs. But let's say that they weigh 110 kilos. You wouldn't give them 11 mLs. You would just give them 10, right? You max out at your max dose in your syringe. And in 15 minutes, if they are still in pain, you can give them a repeat dose of the same volume, right? So open up your second syringe, give a repeat dose of the same volume. So if they were 70 kilos, just running with that example, I would give 7 mLs of volume. In 15 minutes, I would say, hey, how's your pain? Blah, blah, blah. And they would say, oh man, my pain was at a 10 and maybe that helped a little bit, but now it's down to a 9. I'm still hurting pretty bad. Okay, cool. Still in pain. No problem. We'll give the second dose of 7 mLs. So that's how the dosing came to be. And it's interesting because this medication comes from what's called a compound pharmacy in New York, and the compound pharmacy is able to concentrate the medications differently to make the dosing schematics that we needed. So it was actually pretty interesting to learn about throughout this process. So 2 syringes, both with 10 mLs of volume. 2 syringes is 2 doses, right? 1 syringe for 1 dose, 1 syringe for the second dose. 15 minutes between doses. Each dose is 1 ml per 10 kilos of weight. Any questions about that?
I have a question. Sorry,
Sure.
I've had a lot of questions.
You're allowed to ask as many questions as you want, no problem.
What if you have a patient that's like, you give the dose, so you
Mhm.
give your 7 mLs, but then you have a patient who's still writhing in pain and you need to give more pain medicine before 15 minutes?
Yeah, so that's hard, right? So the way that this would work is 1 dose, and then because they're enrolled in the study, has to be like the 15-minute wait, and then second dose. After the second dose, you are able to manage their pain based on whatever your normal practice would be in your protocols. So so that's a really hard thing, because I totally get that. Like, there are patients that, we give our 7 mLs and like the 70 mics of fentanyl didn't touch them, or 70 mics fentanyl, 7.5 milligrams or 17.5 milligrams of ketamine, whatever we gave them, didn't touch them. They're still writhing in pain. Like, what do we do? And that's unfortunately one of the hard things, is that, like, for the enrollment of the study, gotta wait the time period to give them the second dose. But after the second dose, we can give them as much, I shouldn't say as much medicine, that's probably not good advice, but give them whichever dosing of medication that our protocol dictates. And and I'm going to maybe defer to Dr. Wolfson a little bit here for guidance in your system and how you guys would how you would play that. But from an enrollment perspective, that's how that goes.
Yeah, I would say, I think that's going to be a rare situation. So stick to the protocol, wait the 15 minutes, but overall, it's patient-centered care. So if you did run into a situation like, I don't know, severe burns or something,
Yep.
where your clinical decision is that patient needs more medicine now, then just do it, and then it'll just be a protocol violation. I would just just reach for your regular medication. So 100% try to stick to the 15-minute protocol. Use the 2 study syringes, and then you revert to your regular, whatever you would normally use. And you can choose. You don't know which you gave, fentanyl or ketamine, in the study drugs. So once you go past the second dose, you can just choose whichever one you want. Either one will be fine to use, because you'll still be within your allowable doses. But if there's a situation where you just like, there's no way this patient can wait the 15 minutes, and just do what's right for the patient and reach for, choose what you want and just go off the protocol. I hate to say that, but I think patient care always needs to come first.
Yeah, absolutely. And to piggyback off of Dr. Wolfson, I probably shouldn't say this, but if I take my research hat off for a minute, at the end of the day, I'm a paramedic, and I don't care about this study as much as I care about you just doing the right thing for the patient, right? Do I want you to enroll the patient and do I want you to enroll the patient and stick to the protocol? Absolutely. Like, that's super, super important. But at the end of the day, doing the right thing for the patient is the most paramount thing that we do, right? So if you encounter that situation and you're just like, there is no way this is going to work based on whatever the clinical situation might be, then that's okay. That happens. But if you can enroll the patient, please try to do that. I think that that's important. But that's an awesome question. And I love questions like that, because it shows that your head's in the right place, right? Thinking about what's really important, which is the patient. So, all right, hang on. There was a whole bunch of stuff that popped up in the chat. I just want to make sure I don't miss anything. Yes. So the questions in the chat are about EFIC notifications in upstate New York. Yes. So we're going to talk about that in a moment. So here's the workflow. Okay. You're gonna fly to the scene or the referring facility, depending upon whatever the situation that it is, and you're gonna make patient contact. And when you make patient contact, the first things that you should do are always your normal first patient contact things, right? Let's make sure their airway's under control. Let's make sure all the bleeding is stopped. Let's do all of those normal patient contacty things, right? And then we're going to evaluate the patient, and we're going to run the inclusion criteria and say, is this a trauma patient going to UVM that has a shock index of greater than or equal to 0.9 and an elevated pain score of greater than 5, or a 5 or greater, or a CPOT of 2 or greater? If the answer to those questions is yes, and they do not meet the exclusion criterias, right? So they have an IV, no pregnant, no prisoner, no pediatrics, they're not hypertensive, they don't have an allergy, they don't have any voiced objection, so on and so forth. If they have met the inclusion and not the exclusion, we'll take our little brown Ziploc bag out of our bag. We will open the kit. We'll take our syringe. We will figure out how much they weigh. we will administer 1 ml for every 10 kilos. So let's say 80. If they're an 80 kilo patient, we'll go ahead and give them 8 mLs of volume. We will wait our 15 minutes and we'll reassess. If after those 15 minutes they tell us their pain is 0 and they're no longer in pain, cool. We don't have to give the second dose. If they tell us they're still in a ton of pain and they still have a pain score of 5 or greater or 2 or greater, then we can take our second syringe out. We can give our second dose of pain medication at 8 mLs, and on with our transport we go, and we can manage their pain as we normally would after that. Once we land at the University of Vermont, we will go in, we'll transfer care, just like we always do for every other patient. We will take both of our syringes and whatever volumes we have left. So let's pretend we gave 8, right? We would have 2 mLs left in each syringe. 2 mLs of volume left in each syringe. We'll waste that based on whatever your normal policy and process is. Waste just like you normally would. And then on that brown package, you're going to scan the QR code with your phone or with your iPad, whatever you use. And you'll answer a couple questions, which I will show you here in a moment. And you're done. You'll leave the brown packaging with the patient. So in most hospitals have created, and I do believe Vermont is as well, they'll have a drop box in their trauma room or in their emergency department, depending upon how their hospital is set up. And it just looks like a mailbox. And I'll show you a picture of one. And you'll just drop the study kit in that little mailbox and you're done. Really simple. And this is what I just said in bullet point form, right? So I don't necessarily need to read it again. So this was a slide that we worked with Dr. Wolfson to add that talks about sort of some of the things that we already talked about. So if a patient requires additional pain medication following 2 doses of the pain study medication, Vermont EMS clinicians should do the following, right? And if your protocols at Healthnet are different than the ground protocols, this may be a little bit different for you, but you should follow it based on your protocol. So assume that the medication that you are dosing with is they have already received 2 doses of whatever you're picking. So like if you decide, hey, they still need pain management after they've gotten the study medication, 2 doses of the study medication, we're going to go ahead and give them some more fentanyl. You would dose them with their third dose of pain medication as if it were their third dose of fentanyl. Dr. Wolfson, will that be the same with the air service as well as at the ground service? I wasn't sure if their protocols were different, and I didn't think about it actually until just now.
I think so, but I'll defer to Doug and Maddie on that one.
Yeah, so we don't have the same upper limit and no requirement to call for medical direction. So just continue to dose as you would with the expectation that, if you want to give ketamine, presume that they already got 2 doses of ketamine. If you want to give fentanyl at this point, presume that they already got 2 doses of fentanyl and dose appropriately based off of our guideline. We don't have the upper limit requiring med direction contact. So
same process, just different dosing schematics, if you will.
Correct.
Okay, cool. Awesome. These are, for lack of a better word, checklists. So they're really bright, like obnoxious traffic cone colored green. And they will be with those brown Ziploc bags. So they are essentially a wrap that goes around them that will provide you with a checklist, just like you would manage an airway with an airway checklist. This is like a pain study checklist. So when you pull that out, this will be right in your face, and you're able to essentially run one side of the list to say, hey, they met this, this, and this. They didn't meet this, this, and this. Okay, we're good here. We can go ahead and do it. And then on the back side has that CPOT reference score, reference chart as well, for anybody who would need to potentially take a look at that. Somebody asked, I can't remember who it was, but about from a transparency perspective, how do we discuss this with the patient, right? So this is a hard thing, right? Because when a patient says well, what medicine are you giving me? I don't know is probably not a great answer, right? So how do we approach this? So there's some scripts that can be available to you as well. But here's how I think about this. EFIC stands for Exception from Informed Consent. And this is something that it took me a long time to wrap my head around. Remember that consent for treatment and consent for research are not the same thing. So this patient is consenting to be treated medically for whatever their problem is. And it's hard to take somebody who like just got hit by a car and be like, "Hey, I know you're having a really bad day, but I'd like to study you because you broke your pelvis." Like that's a hard thing to do. And the federal government recognized this and realized that it probably wasn't practical to have those kind of conversations. So the way that EFIC works is if you have a patient that is in an emergent resuscitative situation where it would be unreasonable to discuss with them the thing that you wanted to study in real time, you are able to do that thing without talking to the patient about it, because it would be in the best interest of the patient. And then at the hospital folks take care of all that research consenting on the back end. So it's not that they're not getting consent, they're just not getting it in the middle of the road or in the middle of whatever situation that you are in. So you're able to not have to talk to them necessarily about the research side of it in real time. However, we also know that when you talk to a patient about pain management, they generally fall into a couple buckets. When you say to a patient, "Do you want some pain meds?" they usually give you one of the following answers: "Yes, please," "No, thank you," or "What are you giving me?" Right? And most patients say yes, please, or no, thank you. Very seldom do patients ask us what we are going to give them. They're just happy to have their pain managed. So if they say yes, please, you should manage their pain. You should manage their pain based on just the normal practice, right? Okay, awesome. Let's get you some pain meds. We're going to get our meds drawn up, so on and so forth, and we give them what we give them. If they were to inquire to you and say, "What are you going to give me?" I don't know is probably not a good answer. So you should say to them that our trauma system is participating in a research study that compares fentanyl and ketamine, which are the two types of pain medicines that we carry. And because of that, we're going to give you either fentanyl or ketamine, but I don't know yet which one we're going to give. And once we get to the hospital, we'll be able to give you more information about it. So that's how I swing it. We're looking at which pain medicine is better. And because of that, I don't know which one we're going to give you yet. But as soon as we get to the hospital, we'll be able to get you more information and they will say, okay. Right. And that's a hard conversation to have. It's kind of uncomfortable. I get that. But as a general rule, most of the time, it probably doesn't come up. Right. And each service's medical director is able to have the scripts that we provided and is able to sort of help add or subtract anything that they want, and is also able to decide within their system, if someone were to ask you, this is what you should tell them. But the general rule is the scripts are a good guideline, as they have been approved by all of the research bodies. As silly as this is going to sound, let's talk about this QR code for a minute, because we have encountered, remember, like restaurant menus during COVID, right, where nobody could figure out how to scan the QR code. We have sort of figured that out a little bit in this study. So open your camera, hold it over the QR code. You'll get a little thing that comes up on the camera screen. You click it and it will open this link. And when you scan the QR code and open the link, you're going to have a page that looks like this square box on the right side of the screen here. And it's going to ask you a couple questions, and they're very straightforward. What trauma center did you take the patient to? So you'll select the University of Vermont. You'll select what's the name of your EMS service. You'll put your name in as the enrolling paramedic, and then a brief description of the patient. And it doesn't have to be a long HPI type thing. It can just be very clearly, 31-year-old male struck by vehicle, right? Or something very generic. And then you'll answer some yes, no questions. So did the patient meet the inclusion criteria and the exclusion criteria? Yes or no. Did the patient have a pain score based on which scale, and what was the score? What kit number was it? What kit number was it? Um, and and Was the study given according to protocol? And you click register and you're done. Danielle asked in the chat, does it have to be a paramedic? No, it definitely doesn't have to be a paramedic. It could be a nurse or a paramedic, totally fine. If you have a physician or a mid-level practitioner flying with you, that's also fine, as long as they have been trained on the study and it's within their scope of practice. No big deal. So, so that's what the reg form will look like. And then you'll click register. And when you click register, you'll get this little pop-up that comes up on the screen that says the patient has been registered, and you can just click close and it'll close out of your close out of the page and you'll be done. Funny story, please do not repeatedly click register until something happens. Sometimes it works and it, for whatever reason, it like people didn't see the thing that popped up. We had a paramedic in the city of Charlotte register the same patient like 8 times, which is sort of funny to think about, but our data people were not super happy because it screwed a whole bunch of things up in their system. So just click it once, it will work. It's very anticlimactic, but it will work. Will the PIs have access to our run forms to trend vitals for pain, or does the hospital, or does that come from the hospital? It will come from both. So the PIs will, so I guess it's kind of multifaceted. So the PIs at Vermont, as well as the Vermont research folks, will have access to the run forms. And then that information from the research team at Vermont gets put into a system called Florence that then goes to like the research data people. So the answer to your question is yes, they will have access to the run forms at the University of Vermont to pull that information and then upload it into the research system. But the physical run form beyond the University of Vermont, I do not believe goes to anyone else other than the hospital systems. So what if the QR code doesn't work? This is a very seldom thing that happens, but it is possible that you end up in a situation where you just don't have good cell phone service or whatever, and the kit just and the QR code just doesn't work. Please don't panic. It's not the end of the world. There's nothing that says you have to scan the QR code, within 5 seconds of giving the study drug medication, right? It's perfectly possible that if you need to wait until you get to better service to do that, that's not the end of the world. All we ask is that the QR code gets scanned as soon as feasible, because that's what gets the ball rolling at the hospital for the enrollment. Worst case scenario, if your QR code is just like not working, you can't figure it out, contact whichever your appropriate channels would be at your system, and they will be able to help guide you from there. Time of enrollment does matter. So from a documentation perspective, we should document what time we enrolled the patient in the study, no different than you would document the time that you gave any other medication to anybody. But of note, in this study, an enrolled patient means the kit was open. So I really stress to people, don't just pull the kit out and open it and then set it aside and say, oh crap, we can't enroll them, because then you've still enrolled the patient because you've opened the kit. So don't open the kit until we are sure we are going to give it to the patient, because if we open the kit at the last minute and then give it to the patient and it's an enrollment, that's fine. But if we open the kit, then we decide, oh crap, we can't enroll them for XYZ reason. Then we still have to scan a QR code. It becomes a thing. And it's not the end of the world. It happens. But certainly we would like to not enroll patients that don't meet the criteria. So wait until we are sure the patient is eligible and then open the kit. Just some other things. This is the picture of the drop box at the University of Pittsburgh in their EMS room in their emergency department. A similar one was sent to Alex Newman to hang wherever it will be hung at the University of Vermont. But once you scan the QR code and transfer care and do all of those things, you are able to just take that brown colored packaging, drop it in the drop box, and then you will be done. If they don't have a drop box, you are certainly able to just give the packaging to the trauma team or to the nursing staff or whomever when you transfer care. That's no problem. But if they do have a drop box, you're welcome to put it in there. You just have to follow the process for wherever it is that you work. Please, 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 however, do remember that the only thing that goes in the drop box is the empty packaging. Please waste all of the unused medication prior to putting the packaging in the drop box. The sky's the limit with creativity. When the Pittsburgh site went live, here's your other funny tidbit of the morning. Somebody couldn't figure out why they couldn't get the packaging with the syringes to fit through the slot of the drug box. So they wasted all of their medication into the drop box. And that was awesome of them to do. So if it doesn't fit with the syringes in it, it's because the syringes aren't supposed to fit. So waste all your meds and then put the empty package into the drug box. It's okay. You can laugh. We did too. But nonetheless, it really wasn't that funny. Yeah, Michelle, what's up?
Worst case scenario, what if you lose the packaging?
Yeah. So if you lose the, because this will happen, right? Like it'll get thrown away, or something. This isn't written anywhere, but this is what I have told people to do. The only reason that we submit the packaging is because it has the information on the label, right? For the QR code and the kit numbers and blah, 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 right? The physical packaging is not actually that important. What I recommend people do is when you pull the study kit out of your bag or wherever it lives to give it to the patient, take a picture of it just like you would with like a ventilator screen for vent settings or something. And then you have that information and you could still scan the QR code if you needed to. You still have the kit number, so on and so forth. And then you have it that way, and you could at least attach the picture of the packaging to your PCR if you needed to. If you lose it, it's not the end of the world. It's not ideal, but it will happen. We've had them before. Somebody's cleaning up an ambulance, didn't know any better, and they got thrown away. It happens. Yes, Emily, yes.
Hey, so I had a question kind of unrelated to how to dispose of the medications, but can you talk about perhaps if we like encounter a patient, let's say from like Richmond Rescue, who has already been enrolled in the trial, are we providing analgesia from either our package also, or are we ever in a situation where we would be taking their second syringe with us? Does that question
Amazing.
make sense?
Yeah, no, that's an
Okay.
amazing question. And you guys are a little bit of a unique situation because you're one of the only places where the ground system also has this study medication and could potentially be referring a pain enrolled patient to you. So here's how that would work. If Richmond Rescue enrolls the patient with their kit, when you land and you transfer care, they need to take all of the syringes and waste their own medication, like don't take their drug, and you just take the empty package with you to the hospital. If they have enrolled the patient, you are not able to continue enrolling with their syringes. So like they can't say to you, we gave them one dose, here's the second syringe, give it on the way. It doesn't work that way. They were enrolled with their kit, so they have to They have to be the enrolling body. They have to scan the QR code, so on and so forth. But it's reasonable for them to give you the empty packaging to take with you to the hospital to transfer care. So you would not continue to enroll the patient. You don't actually have to do anything in that situation other than drop the little package in the drop box when you get to the hospital. But they should take care of all of that. They should take care of the administration, the wasting, and then giving you the package. Does that make sense?
Yeah, thank you. That was a big question I had in my mind. Yeah,
Yeah,
thank you.
no, and it's a super question. When this first rolled out, there's a place in Pittsburgh that has, a suburb of Pittsburgh that has it on their ground units, and then the Pittsburgh Air Service does not have it at all. So when this first rolled out, it was how to sort of figure that out, because certainly we don't want people transporting, narcotic syringes that aren't theirs, and so on and so forth. So it was a super great question. As it relates to charting, you should chart this. You should chart this just like you would chart anything else, right? So your PCR should include your pain scores. It should include, we gave 1 or 2 doses of the study drug at X amount of volume. Anything else they got, any airway attempts, the kit numbers, the shock index, all of those normal things that we would chart are things that should go into the trip sheet. And it's important to also remember that we can use qualifying vital signs that we didn't take. And what I mean by that is, going with the Richmond example for a minute. Let's pretend that we land at a scene and the Richmond EMS folks tell us that this patient, upon their arrival, had a heart rate of 120 and a blood pressure of 100 over 80, let's say. And those were their vital signs. Well, according to those vital signs, they have met the shock index criteria, right? 120 divided by 100, so 1.2, right, would be their shock index. So they met their shock index criteria, even though we didn't take the vital signs. You can use that set of vital signs as like their inclusion for the shock index. You just have to chart them, right? So you could chart in your PCR, Richmond EMS upon their arrival discovered the patient with a heart rate of 120 and a blood pressure of 100 over whatever I said, 80 or something, and therefore the shock index was 1.2. Like you can chart that and use those vitals. That's no problem at all, as long as you chart them. In addition, right, in just good care, right, I don't have to tell you guys this. Getting weights of the patient, is important. Making sure that we have good documentation is also really, really important, because, as you know, that is the record of what happened. And yeah, Michelle.
Yeah, just kind of going back to Emily's question. So if we'll use Richmond, for example, still. So Richmond enrolled the patient in the study. They did it. They gave their meds. Can we also do it, or do they need to be out of the study at that point?
No, so they can only be enrolled once. So if they
Okay.
did it, they would still be in the study, but they would be enrolled by Richmond and not by you. Does that make
Got
sense?
it. Yeah,
Yeah.
perfect. Thank you.
Yep, and you don't have to do it's kind of nice, right? Like the patient gets to be enrolled and you don't have to do any of the work. The only thing you have to do is transport the empty package with you to the hospital. Cool. Dave, go ahead. Dave Weiss, did you have a question?
Hey, yes, I did, and I actually just forgot it. I will put it in the chat when I remember. Sorry.
Yeah, no worries.
I'm going to jump in for a second because I have to hop to another meeting, but I just wanted to say a huge thank you to everybody for participating in this. And also just, we've been waiting for 20 years to get involved in a multi-center national study like this. And the Pittsburgh Lights Group is just phenomenal. This is a unique opportunity for us to be involved in real deal national level EMS research. I'm so excited that we're able to be a part of this. So thank you for making it possible. And I think the Vermont team, and especially Healthnet, is really going to rock it. And we're going to present good data with few violations, and Lights is going to love us. And then that means we'll be invited to participate in other really cool projects in the future. So that's my pep talk. Thank you so much.
Yeah,
I'll turn it back to you.
Yep. No problem. Thanks for being here. Appreciate it. Yeah, Dave, did you remember?
I sure did. Sorry about that.
All good.
If we are doing short transports, hopefully in the near future we'll be doing intercepts. If we intercept someone like 15-ish minutes out from the hospital, so that we give them the medication 10 minutes outside of the hospital, knowing that we won't be able to give them that second syringe, are they still able to be enrolled in the study, or is the goal to give them both if needed?
No, so you can absolutely still enroll them, right? So it would be no different than like I gave them the first dose and then they got better, so they didn't need the second dose, right? It would be like the same thing. So if you give them a dose and then you are at the hospital prior to them needing their second dose, then that's fine. It's kind of just like the clock stopped because you got there. No big deal.
Perfect. Thank you.
Sure, no worries. All right, so back to charting, right? So all the normal things that we would chart. In addition, also remember that we should chart things that happened that were unexpected, because as we know in medicine, sometimes even when you do all of the right things for the right reasons, people don't react the way that we thought that they were going to react, right? We have all at some point or another given a patient something and then watch them get hypotensive. And we were like, oh, that wasn't supposed to happen, right? So we have to fix it. All of those things are important. We want you to document them. You're not in trouble. We understand that medicine is what it is, and sometimes that happens. Chart them, right? Because that's important to know. And then most importantly, fix them, right? For example, if I give the study medication to a patient and they all of a sudden have a significant decline in their respiratory rate and they get hypoxic, it would be reasonable in resuscitation to give them Narcan, right? There's a 50% chance I gave them fentanyl. If I gave them Narcan and it didn't make them better, then it's not going to hurt them. But we could certainly use that as part of one of our resuscitation mediums. So important that we A, recognize any adverse events that happen, B, and most importantly, fix them immediately, and C, chart them, because we want to make sure that we have record of those things happening. And then chart, obviously, how you fixed it. From a responsibility perspective, this is, I will tell you, this study is a huge undertaking from the EMS system medical directors because of what they have to do as it relates to ordering medications from the compounding pharmacy, ensuring their delivery, the training that they had to do for that, et cetera, et cetera. So there is a significant amount of work that has to be done from the medical direction level on this study, and that they'll have to document different things in conjunction with the research team. And then the research team, Alex Newman, who's the research coordinator for this project at Vermont, has been phenomenal to work with, and he makes sure that all of the EMS systems have what they need from a support level at the hospital. From a tracking perspective and an accountability perspective, remember that these are essentially narcotics in your aircraft. So you should treat them just like you would treat any other controlled substance in your aircraft as it relates to tracking and record keeping and so on and so forth, and doing good unit checks. Should you find that you have a kit that is damaged, missing, so on and so forth, report that through your appropriate channels at your agency, just like you would for any other controlled substance issue, and then they can tackle it from there. We had a kit at an EMS service in New Jersey not too long ago that actually got stolen um, out of an ambulance. So it happens. These things happen, and we will help you work through it. But manage it just like you would manage any other controlled substance.
Jonathan, I'm going to jump in here because anticipating a question we are working through with Miles and the pharmacy, just as the district services are, of how the syringes are going to be part of our kits or attached to our kits. We're working through those pieces and parts of it, and we'll have it all in place before we start the study.
Cool.
Jeff?
Awesome.
I was just wondering if you had an idea of the expiration time, since it is a compounded medication, and how frequently we may need to address that.
Yep, it's quarterly.
Thank you.
Yeah, no problem. Compounded medications have a much shorter, as Jeff said or alluded to, I guess I should say, have a much shorter shelf life than I hate to say regular medications, but regular medications. So quarterly, quarterly. Dave Weiss, will all the VT will all the VT services be going live at the same time? Yes, July 1st, as I understand it, is the plan. I will double check that with Rachel Monera, who's the project manager for this, but July 1st is the plan for Vermont, as I understand it. Don't 100% quote me on that, but I believe that is the case.
Jonathan, I think I remember she was hopeful for July. I didn't hear July 1 as being firm, but that was the goal.
Yeah, it had to do with I don't know all the specifics because I don't necessarily do that part of it, but it had to do with the ability to just get the volume of kits shipped
That's what
up to Vermont.
Yep, that's what she had said.
Yeah, so July 1st-ish, heavy on the ish. All right. So that is the meat and potatoes of this. This is the part that we have to tell you about as a requirement of this study. And here's the deal. This is like 10 slides on research that are like super dry and terrible. But it is important. And here's the trade-off. Has anybody ever taken the Research City, CITI modules? They are research modules that you have to take for the government that explain like good ethics and research and blah, blah, blah. And they take about 30 hours to complete, all of them. We are able to only make your medical director do that under the caveat that you guys get these 10 slides. So, although they're kind of boring and terrible, it was the trade-off. So here's the deal. So remember that this study is research, right? Like Dr. Wolfson said, like this is literally like a double-blinded clinical trial. Like this is real research. And we're doing this because it's in the best interest of the patient, and we always act in this patient-centric world. And to do good research, we have to have good clinical care, and that is, a patient-centric attitude. That is good documentation, good protocol adherence, so on and so forth. And then from the hospital side for this study, good relationship building with the hospital and then with the family and the patient for consent. So for good clinical practice in the EMS world, right, we have to document this really well. We have to really make sure that we are adhering to the inclusion-exclusion criteria and following the rules of research, which basically, as my mother would say, just be a good person. And if you do that, and if you're a good person and you adhere to the protocol and you have a good attitude and so on and so forth, we're going to be totally fine. And if we do all of those things from a research side, on the research side of the house, they will then go through and retract the data quality and the data that we need and so on and so forth, and can consent the patients, and they will take care of all of that. So if we have good ethical standards and good clinical care with good data, we're going to have good clinical practice. And I refer to this slide as sort of the circle of life, right? So basically, for all of these things, for good research to happen, there has to be like all of these things that fall into place, right? Like first of all, we have to have um, we have to have like really good ethics, right? Like we have to always be we always have to be functioning, under these ethos that the patient's safety and rights to being protected and so on and so forth are always the priority. And then we compile that with good science. Like we have to be able to say this is a real question that there's value in being answered. Like we don't collect data just to collect data. That's stupid. But we have to have really good science compounded with those ethics. And then we have to have responsible parties that help make sure that we are sticking to the good science and the good ethics. So the IRB, the Internal Review Board at the University of Vermont and the University of Pittsburgh work together to make sure that the University of Vermont's IRB makes sure that the University of Pittsburgh's IRB is acting in the best interest of the study and in the patient, and vice versa. And it creates that checks and balance to make sure that everybody is safe, everybody is doing what they're supposed to do. And then we do that. And in this study, this is conducted under EFIC. So, and we talked about that a little bit. So EFIC means that we don't have to get consent from the patient before doing the thing, right? So in the back of the helicopter or the back of the ambulance, we don't have to consent the patient to research right there. But as soon as we get to the hospital, somebody from the research team, as soon as it is feasible for the patient, has to discuss with the patient and or their family about the research study. So kind of like I mentioned, it's not that we're not consenting them. We're just consenting them at the hospital after the fact. So we have to always have good continued consent, and that consent has to be continuing throughout the process. So as soon as the patient, if we get to the hospital and the patient says, yeah, would be happy to participate, no problem, great. And then in a week, when we revisit the patient, we say, hey, are you willing to continue to participate? And they say no, we stop. We no longer redact data from that patient. We'll keep everything that we obtained during the period where they were consentable. But if they withdraw their consent, then we stop. So that process has to be ongoing. And in that ongoing process, right, we collect good data and we keep, we have good integral data, meaning the researchers don't know what we find because that would create bias, right? So like I will not know what this study is finding. Dr. Guyette and Dr. Sperry, who are the PIs, Dr. Wolfson, for example, they will not know what this study is finding as it relates to the study until the study is over, because we don't want to have bias, and that is that good control and good assurance of that. And then obviously the investigational products that allow this to all happen. So it's really this multifaceted circle, and this multifaceted circle happens on a lot of different levels, right? Like the IRB is just one level, but like the FDA has rules and regulations that we have to follow. And then the IRB is what makes sure that we're following the FDA rules and regulations. And then we have what's called the Data Safety Monitoring Board, or the DSMB, that monitors the data. Because like I said, the researchers can't know about the data we're collecting and what it shows during the study, because that creates bias. But somebody has to be looking at the data to make sure that continuing the study is safe. So the data that we collect goes to a group of physician researchers that are not affiliated with this study whatsoever, and they monitor the data on a regular basis throughout the study, and they look at it to make sure that things are safe. Because if we were to do this and we were to find out that the study was really, really unsafe, we would need somebody to say, we got to stop enrolling people, right? This isn't safe. Or oppositely, if we enroll the study and we say, everybody that gets, and they find that like everybody that gets fentanyl dies and everybody that gets ketamine survives, we would also need to stop and say, like, we found an answer really quickly, so we don't even have to continue. So the DSMB, and that is very, very rare, but the DSMB is what monitors the data through the study to make sure that things are acting safely and that it's okay to continue or not. And from a GCP perspective, you can help us, and you can follow the rules for good clinical practice by really, the biggest thing is only enrolling the people that should be enrolled, right? Looking at the inclusion, not the looking at the inclusion, making sure they meet it. Looking at the exclusion, making sure they don't meet it, and then giving the right dose of the patient, and then subsequent right dose of medication to the patient, and then subsequently scanning the QR code, charting that whole process really well, and then moving on from there. That is really how you guys can help us, right? And it takes a village, right? It really, really does. So the DoD is the sponsor for this study, and they're the ones that fund it. But the investigators, the investigators that really, design it with the research folks, and all of the other entities for data and so on, are like the really small minorities. Like the folks that are out there, the 4,000 paramedics and the clinicians, I say paramedics, but EMS clinicians that are out there, they are really the people that are making this happen. Without that, there would be no study, right? So you guys are really the backbone of what we're doing to make this happen. And I think that it's important that you should recognize that, as Dr. Wolfson said, participating in this and participating in research studies like this is truly an honorable thing, and you should be very proud of that. There is actual science that says that EMS agencies and healthcare entities that conduct research provide better care, right? So you should be very proud of that. And then very briefly to wrap this up, right, let's just talk about this consent process. Even though you were not consenting, I want you to know about it. Most of the time, research consent happens prior to the intervention. But as we mentioned, in emergency situations, that would just not be reasonable because of the need for rapid resuscitation. So EFIC allows for rapid resuscitation to happen with research being conducted at the same time, um, and then getting that consent sort of after the intervention at the hospital. And there are a whole lot of rules for the hospital as it relates to this. But what you should take away from this is exception from informed consent does not mean that they are not consenting to research. It means that they are just consenting once you get to the hospital, right? So they are still consenting. They still have the ability to electively not participate or electively participate, depending upon how that shakes out. But it happens at the hospital after the fact. Right. And this is EFIC research can only be done in emergency situations. Like we can't just EFIC study whatever we want. It has to be a life or limb threatening disease pathology that we're studying to do this. And there has to be significant evidence that says that conducting this would be of benefit to the patient and of the community. And there are a lot of review processes that have to happen prior to this going live. Like Dr. Wolfson said, this project has been ongoing for several years with Vermont's involvement. There was probably a year and a half or more worth of work that happened before we even got to this point this morning. And part of that happens is this community consultation. So what happens is, and somebody had asked about this in the chat, is we have to, and when I say we, I mean, Lights in conjunction with the researchers at the University of Vermont have to make the public aware that this study is happening because they have a right to that. So they sample a population in the study or in the community, and most commonly that is vulnerable populations. The easy example is our religious groups that do not wish to have blood products, right? Like that's an easy example. And we go to them and we say, listen, this is a study that's happening, and we put information out there, on the radio, on the news. In Pittsburgh, it's on buses, like it's all over the place. And there's a public comment period and so on and so forth, and they have the ability to opt out. And what's interesting is when we go to these vulnerable communities, usually they're actually very supportive of the research. They're like, yeah, we think you should study this. This is important. I'll take 500 opt-out bracelets, but we think it's really important. So they have the ability to be aware of this, and that's well within their right. If you go to our website, you can go to the Lights Network website and go to the pain page, and you can see all of the community consultation things that are there. In Pittsburgh, there are several things out there for some of our different studies, but this is one of the signs or billboards or whatever you'd like to call it for this study. For this study for the public as well. So that's what I have for you this morning. As we have done done these educational sessions, we have encountered some frequently asked questions that I will just buzz through with you really quick, and then happy to answer any questions anybody has. What if I open a kit and don't use it, right? Remember that once the kit is open, the patient is enrolled. So if you open the kit and ended up not giving it to the patient, for one reason or another, maybe they didn't meet the inclusion criteria or something, or maybe you opened the kit because they met all the criteria, and then while you were opening it, they had a cardiac arrest, right? And we had to shift our efforts to that. Once the kit is open, we still waste all of the medication just like we normally would, and then scan the QR code for the enrollment. What if I drop the kit on the floor and break it? What if I drop on it, step on it, it gets contaminated, whatever. One kit per patient. So if you damage a kit, for the patient, you can't just pull out another kit from your bag and do it that way. So one kit per patient. What if the patient's larger than 100 kilos? Remember that if they are larger than 100 kilos, please just give them 10 mLs per dose, right? Maximum volume in the syringe is 10 mLs, 10 mLs per dose. Please, please, please do not combine the syringes. That is not a good plan. So 10 mLs per dose. What if I don't use the second syringe, right? For any number of reasons, like somebody had asked, what if I get to the hospital before I get my second dose? No problem. You just waste the whole second syringe and then document it appropriately. What if I divert to a hospital or hand off to a flight crew? So we talked about this, right? What if the ground service hands off to the flight crew? The diversion thing is interesting. So let's pretend that you're flying to the University of Vermont, and while you are flying to the University of Vermont, you enroll the patient because they met all the criteria and so on and so forth. And then while you're there, the University of Vermont says, I don't know, we had some disaster and you can't land here now, right? Because that happens sometimes. You are intentionally enrolling the patient correctly, right? Like when you did it, all of the information that you had was correct. It wasn't your fault that a hurricane came through and blew apart the helipad. So what do? You divert to whichever hospital that you're diverting to, and you still scan the QR code. You do all of those normal things. You leave the package with the receiving emergency department, and then our research team will reach out to whichever hospital that you diverted to, and they will take care of it from there. It's not your fault. It's EMS. Sometimes those things happen, right? Sometimes things happen that are out of our control. It's not the end of the world. You're not in trouble. It's not any of those types of things. It's just a freak thing. So you can still enroll the patient. It's not the end of the world. But that's the process that you would follow. Now, if you know that you are not going to the University of Vermont, please don't enroll them, right? But if you enroll the patient and then something happens and you have to divert because of weather or whatever, not the end of the world. What if the QR code doesn't work? My short answer is just be patient, right? You're probably in a place where there's just not good service. Wait till you have some better service and then scan it. But if it truly doesn't work, reach out to whichever the appropriate channel would be at your system, and they will help you through that process. What if the patient has an allergic reaction? As you might have suspected, manage their allergic reaction just like you would manage any other allergic reaction. What if the patient doesn't have their pain controlled, right? So after 2 doses of study medication, their pain is not under control. What do? You manage them with continuous pain medication after the second dose of the study drug via your protocols and guidelines as you normally would. What if the patient can't verbalize the answers to the exclusion criteria? So for patients that are not able to do that for whatever reason, you can use the nonverbal communication or so on and so forth. Again, you're taking my research hat off. I'm a paramedic. I'm a realist. If you're really just not sure, just don't enroll them. Err on the side of caution. Don't enroll them. And what do I do if I have questions following this training? You're welcome to reach out to us at any point, obviously, but also the appropriate channels within your EMS system, right? So that's what I have for you. Please remember the inclusion-exclusion criteria. So adult trauma patients going to the University of Vermont, pain score of 5 or greater or 2 or greater, depending upon the score you use or the system you use, and a shock index of 0.9 or greater. Be a good person, be a good clinician, and you will be just fine. Any questions as it relates to this study? And I know that I probably went through that a little bit fast, and I apologize, but certainly wanted to make sure that we got to everybody's questions and so on. So anybody have any questions? Okay. Well, here's the next thing that we're going to do. So on the screen, there is a QR code. I'm also putting the link to the QR code in the chat. This, if you can't scan it because you're on your phone or whatever, this QR code is the registration for your attendance here at this today to make sure that everybody gets credit for having been trained on the study. You can click the link in the chat or you can scan the QR code. Either way, it'll take you to the same place. But please do that before you hang up so we can make sure that you get credit for being here. And Leslie, I will send you a roster later today.
Wonderful. Thanks, Jonathan.
You're very welcome. And after you scan the QR code, as long as Leslie doesn't need you, I don't want to speak out of turn, but I am done. So you can maybe hang up. I don't know. And if you have any questions, I will hang on until we're good.
Thank you, Jonathan. Guys, for everyone, the fact that we're doing an EFIC is a really cool thing. As far as I'm aware, this is the first one in Vermont, at least the first that anyone who does research that I've talked to has been aware of. We try to do a lot of research. We do some collaborative stuff with some of our local agencies as well, but nothing quite to this degree, right? Randomized, double-blinded, controlled studies. This is definitely the kind of stuff that changes practice, and so it's great to be a part of that. I know this is a company line, but it's not at the same time. This is an opportunity to be a part of a big study that hopefully will make change in practice and guide practice. So it's an extra work, it's an extra step for our patients, but it's hopefully not just treating the patient that we are managing currently, but thinking about how we're treating patients across the country and, in the pre-hospital medicine in general. So appreciate you guys taking the time to be a part of this and contributing to it.
Thanks, everybody.
Thanks, Jonathan. Have a great day. Thank you.
Thanks, you too. See ya. Bye-bye.